Next is about the arshas. Athato arshasam nidanam vyakhyasyamaha yathovata bhagavan dhanvantarihi. Now, arshas, the word arshas means a projection, and it could be like majority of the times it has to be considered as the anorectal projections. I don't say only the piles, hemorrhoids. It's not only the hemorrhoids, even the polyps also could be considered as arshas. Sushra has mentioned about the arshas or projections, polyp-like regions elsewhere over the body, also over the skin, and in the netra also, or maybe even the oral cavity, or in the nasal, nose, so on. So, word arshas is said having a broader meaning, but whenever it comes to the question of specificity, it's about the gudarshas or the anorectal hemorrhoids. Now, Sushra has categorized them into six. षडर्षांसि भवन्ति वातपित्तकफशोणितसन्निपातैः सहजानि चेति तत्र अनात्मवतां यथोक्तैः प्रकोपणैः विरुद्ध अध्यशन स्त्रीप्रसङ्ग उत्कुटुकासन पृष्ठयान वेगविधारणादिभिः विशेषैः प्रकोपिताः दोषाः एकशो द्विषः समस्तः शोणितसहिता वा यथोक्तं प्रसृताः प्रधानधमनीः अनुप्रपद्य अधो गत्वा गुदम् आगम्य प्रदूष्य गुदबलिः मांसप्रलोहान् जनयन्ति विशेषतः मन्दाग्ने तथा तृणकाष्ठ उपललोष्टवस्त्रादिभिः शीतोदकसंस्पर्शनाद् वा कन्दाः परिवृद्धिम् आसादयन्ति तानि अर्षांसि इति आचक्षते. Now hemorrhoids, they get projected out due to certain specific variety of the reasons. The first of the initiation of the lesion would be starting from the viruddha adhyasana, the dietary habits, or it could be due to the physical exercises. Now, physical activities which are mentioned there are one is Stri Prasanga, excess of sexual indulgence, and then Utkutukasana. Now, Utkatukasana is a Buddha-Parshni Samayogaha Prahu Utkatukasana. When the anus and the parshni, the heels, they come together. That's what we call as a squatting position. That's considered as one of the causes of the hemorrhoids. A bit more about that, I will come to that part also. Prasthayana, traveling on animals or maybe the two-wheelers, these are considered one set of the causes, the physical causes which can trigger the hemorrhoids. Vega vidaranadihi visheshehi. Then prakupitaha doshaha ekasho dvisho samastava. These physical causes, they result in involvement of the factors of the tissues, body, dhatus, like it could be the rakta or it could be the other tissues, including the mamsa. Shonita Sahitava, in all that, the majority would be the Shonita. The major component would be Shonita. The Rakta is the major component and it results in a structural incompetency, abnormality of the structure of the body. And Ethoptam Prasadaha, Pradhana Damanihi Anupravadya, and they involve the Pradhana Damanihi, the vessels of the pelvis, and result in the location in the Guda, in the rectal area. And it involves Gudavalihi, the folds of the rectum. Again, we will come to that part also, how and how, why. Mamsa Pravohan Janayanti, Visheshataha Mandagnehe. The another important, the most important central cause for the arshas is mandagni, abnormality of the metabolic activity, digestion as such. And the triggering factors are, again, there is a mechanical component of triggering factors where the friction at the area can increase the complications, and the friction could be trinakasta upalalostostradihi due to any of the hard materials or pricking type of the materials, or shitodaka samsarshanva due to contact with the cold substances. That's also called as that's also a triggering factor by which the projections, they tend to become bigger and they tend to produce the complications. Such a situation is considered as a arshas or hemorrhoids. Now, as we know now, when we classify the hemorrhoids or identify the hemorrhoids in the contemporary system, the hemorrhoids are considered as the varicosities of the anal plexus structures. Now, anal plexus has the blood flow in the anal area has a unique pattern, like you will have a superior venous plexus and a inferior venous plexus connecting by three interconnecting veins which are at 3, 7 and 11 o'clock. And these interconnecting veins of the plexus, they do not have a wall, and hence if there is a difference in the pressure between that rectal and the anal area, the superior and the inferior anal area, it can result in the bulging of the vessels, and that bulging of the vessels can result in the hemorrhoids. So, from the contemporary point of view, the mechanical factors which are like when any of the conditions which can increase the intra-abdominal pressure, or any of the conditions which can produce the pressure in the veins as more, as in case of the varicosities, or maybe the hepatic pathologies, where the cirrhosis like conditions, where the pressure in the inferior vena cava has become increased. So there are two factors now, two aspects of the hemorrhoid formation. Either where there is a increase in the intra-abdominal pressure. Increase in the intra-abdominal pressure can be like a patient who is having a habit of constipation, where the patient is not able to pass the stools and he has to strain more, and it may be that the patient may have to strain more during the micturition in case of prostatic pathology, or it could be like a pregnancy where the intra-abdominal pressure could be increased, or in case of the portal hypertension conditions where the pressure in the veins could be increased, that could be up to hemorrhoids. So hemorrhoids could be up two categories. One where the intravenous pressure is increased, and the other is the intra-abdominal pressure is increased. Or the third possibility is some structural abnormality of these veins, like if the veins are having say fragile walls, that also can result in the hemorrhoids. So primarily there are three categories of the conditions, and the mechanical factors like whether the squatting or sitting, this is another of the issue, controversial issue. Sushila has said that the squatting position can trigger the hemorrhoids. Now, so a few of the studies are already done, and there are some reports of that also. And whether the squatting position increases the hemorrhoids or sitting posture increases hemorrhoids and so on, the data is uncertain. The results of this, there are certain references. I have given you the references, which you can, those who are interested, can go through these references, where there is a control study of these habits and the incidence of the hemorrhoids, and the total data is inconclusive. There is not much of a difference. Whereas the dietary factors are mentioned as the causes. And among the dietary factors which are well known to be the triggering factors for the causes are low residue diet. Low residue diet, as in case of the Western countries. Whereas the Indians, their diet is a high residue diet, and because of the high residue diet, the incidence of the hemorrhoids comparatively would be lesser. But there is another view also. There is a bit of controversy over these issues. The other issue is about the spices used in the food. Because more spices are used in the Indian diet, the incidence of the hemorrhoids could be more, whereas these spices being used lesser in the Western diet, the incidence could be lesser as such. But in general, globally, when you look at the total data of the incidence of the hemorrhoids, there is not much of a significant difference among the Western and the Indian situation now. But what we see now in the Indian data, there is a gradual increase in the incidence of the hemorrhoids now from years to year, and this could be related to the gradual westernization of the food. And at the same time, so you try to westernize the food by following that western material. At the same time, make use of the spices, which is the natural content of the Indian diet. So these two combinations are now becoming the vogue practice, regular practice, and hence incidence of the hemorrhoids in India is increasing much more rapidly than elsewhere. The present situation now, the market study of the possible incident, this scope for the market of hemorrhoid treatment expected by a huge market study done, and it shows like the Middle East and African countries, the incidence of the hemorrhoids is increasing rapidly compared to other areas, other countries. So it is a zone-wise data. The Of course, throughout the globe there is a tendency for increase in the scope for the treatment for these hemorrhoids. That means the possibility of incidence of the hemorrhoids also is more, and it's expected by 2028 it reaches the maximum peak as such. So it's a disease which is increasing in trend, and the causes, of course, are lifestyle as well as the dietary factors are considered to be the major causes, and hence hemorrhoids are now considered to be a preventable diseases by modification of the lifestyle and diet. So there is a significant stress on this change over to the diet and lifestyle. Now, more of that part we will discuss when we discuss the chikitsa later. So, a bit about this also is necessary when we discuss about the etiology of hemorrhoids. Now, of course, another important issue is Arshas is considered as a Mahavyadhi. But from the current contemporary science point of view, modern surgical point of view, majority of the people would consider hemorrhoids as a localized vascular disease or localized varicosity, and it's not considered as a serious disease condition. And as far as the otherwise data is considered, there are two aspects. One, a established hemorrhoid and a hemorrhoid status. Established hemorrhoid is where the veins are bulged and they remain bulged. A hemorrhoid status is a transient condition. Temporarily the veins may get bulged, but they may not result in a permanent bulging. And it's said that about almost about 52% of the population in their life might have expect or experienced a hemorrhoidal status at least once in their lifetime. This is what the data says. Whereas the hemorrhoids, they are seen in around 4 to 5% of the people. So that huge gap between a hemorrhoidal status is a situation where there could be a temporary, transient bulging of the veins due to certain triggering factors like the constipation or maybe the occupational factors or the dietary factors. It could be having a temporary phase, but it may get spontaneously relieved in a good number of patients. And the patients who would have a hemorrhoid permanently would be around only 40%, and the gap is around 50%, and that's a quite a huge gap. And from the clinical point of view, when you go to the management, this constitutes a huge margin asset. That's one of the important issue. Again, more of that part we will discuss more detailed information about that we will be discussing when we go into the chikitsa. Now, Sushruta, when he discussed about the arshas, he discusses with the anatomy of the anorectal area, the guda. The guda is considered as a sadhya pranahara marma. Now, of course, one point which I would like to highlight again would be, so, Shas is considered as Mahavyadhi. Now we consider that this disease is prevalent in a quite a common condition and relatively simple. Probably Sushruta might have considered Mahavyadhi because of the frequent incidents. Incidents of the Arshas was quite huge even in that period. Probably because of that reason it was considered as Mahavyadhi. Anyway, that's one point. Then the next is about the anatomy. In the anatomy, Stulanta Pratipadam Ardhapanjangulam Gudam Ahuhu, the last portion of the Stulantra, probably the large intestine, the last portion, Ardhapanjangula, 5.5 angula of that is considered as Guda. That's exactly what we call as the rectal and anal structures. Rectum and anus, it constitutes the same, like the dimension will be the same. तस्मिन् वलयः तिस्रः अध्यन्ताङ्गुलान्तरसम्भूताः प्रवाहणी विसर्जनी संवरणी चेति चतुरङ्गुलायताः सर्वाः तिर्यगेकाङ्गुलोच्छ्रिताः शङ्खावर्तनिभाश्चापि उपरि उपरि संस्थिताः गजतालुनिभाश्चापि वर्णतः सम्प्रकीर्तिताः रोमान्त्येभ्यो यवाध्यर्थो गुदोष्ठपरिकीर्तितः प्रथमात् गुदोष्ठात् अङ्गुलमात्रे. Now, the anatomy of the anorectal area as per Sushruta is having mainly three layers or three valleys. Now, valleys, and these valleys are described as having a appearance like that of Gajatalu, like the palate of the elephant. Palate of the elephant means somewhat muscular structure. So, very obviously, these valleys are related to the muscular structure. Now, what are these valleys? Now, from the contemporary anatomy point of view, of course, there is a lot of difference of opinion. Many people would like say that it is the bodies are identified with the different structures. But if you look at the real description what's mentioned in Sushruta, and we make a conjecture, the bodies have three functions: pravahani, visarjani, samvarani. Pravahani is the superior most, which presses. The word meaning of pravahani is which puts the force, which helps in putting the force as such. Then Visarjani is which helps in the expulsion. So that's a portion which actually helps in expulsion of the stools. Sambarani is at the end of that, it keeps the opening closed. Sambarana, closing. So Sambarana is something which keeps the structure closed. Now, rectum and anus is such a very complex structure which no machine can copy. Whatever the development of the new technology, till now, no such technology has been developed now. The issue is it's a patent tube. See, anorectal opening is a patent tube. It's never closed completely, but it remains airtight. And at the same time, it can allow the air to flow only selectively, or it can allow a huge solid mass to flow selectively, and it can keep competent. Now, that kind of a tube where there are no closing walls, and the tube just manages on these being manages to be airtight at one situation and allowing a huge mass of objects solids to pass through. Such a tube is not prepared or manufactured by any technology till now. So the most complex part of the anatomy in the system is, or most complex part would be the anus, the God's creation, and human creations are not able to copy. So maybe in a larger sense, we can say like all that scientific progress or technology is not equal to my anus. So that could be a joke as such. So whatever the technology is not even comparable to the anus or rectum. Anyway, that's one aspect. Now, to have these functions of the defecation again, defecation function also is a very complex issue. It starts as a involuntary activity in the newborn, in the children. It's involuntary. In the lower animals also, it's a great to a great extent in majority of the animals, it's involuntary process. And whereas in a human being, you gradually learn to control and defecate at a proper situation where when the proper situation is available. Now it becomes semi-voluntary. So a involuntary object or involuntary activity becomes semi-voluntary where the voluntary control can supersede the involuntary activities to a great extent. Is a very complex learning process, and this learning process involves huge synchronization of the different areas of the body and the muscles, nerves, and so on. That synchronization and the issues related to the synchronization is something which we will discuss more in when we discuss about the dysynergia conditions. The next part, I will come to that part bit more in detail. Now, the point here is there are the voluntary components which can increase the pressure of the abdomen and help in expulsion of the stools, and the involuntary component which produces the sensation for the urge for defecation, and it can, once the initiation of the sensation of involuntary component starts, whenever there is an optimum situation, the voluntary component, the muscles would be putting the pressure and the stools are expelled out. Of course, the other part is about how the gas and the stools are selectively expelled. I will come to that part when we discuss about the design energy later. So for the present, when we discuss about the anatomy and justify the names of Pravahani, Visarjani, Samvarani, I will come to this part like the Visarjani is the layer which stimulates or maybe produces the sensation for the Visarjana, the expulsion, and facilitates the expulsion. And this function is done by the internal sphincter muscles. Internal sphincters are those muscles, there are three bundles of the internal sphincter, and which are actually keeping the anus competent, and the angle between the rectum and the anus is maintained. See, as long as the angle between the anus and rectum is maintained, the pressure gradient helps in keeping this anus closed. So whenever there is a pressure in the rectum has increased due to the presence of the stools or the gas, there will be a stimulus reaching to the higher center, and that higher center will either increase the tone of these pelvic floor muscles. You'll have all that pelvic floor muscles, and those pelvic floor muscles would be either keeping the area contracted or still enhance the angle, or whenever there is a situation where the defecation has to be there, these muscles will be relaxed. Mainly the levator muscles will be relaxed, and that relaxation of the muscles helps in passage of the stools down, and at the same time you will have all the musculatures of the abdomen including the diaphragm, which tend to produce the pressure, increase the intra-abdominal pressure. So that actually voluntary component of the defecation starts with the relaxation of the levator ani muscle. That's the pravahana. So pravahani is that ring-like levator ani muscle or the whole pelvic floor. I would not say only levator ani, all the pelvic floor muscles which are responsible for keeping this anus and anorectal junction as a closed structure, and whenever there is a need, it can open up and help in putting the pressure. That's the pravahani. Visarjani is the internal sphincters which will start the stimulation for the defecation, and at the same time when the defecation occurs, these should relax. See, in internal sphincter muscle should relax so that the anal pressure gets reduced, and due to the pressure from the superior area, the stools get expelled out. Then external sphincters, usually we consider them as relatively less functionally important. They are very thin fibers and they keep the skin closed, the wrinkles of the skin. They have a cutaneous insertion, and the skin of the anus, they will be closed. In lower animals, these external sphincter, like cows and so on, the external sphincter muscles are quite thick, and they themselves will be responsible for maintaining of the closure. Like, see, if you look at any animal like cow or goat, when it defecates, at the end of the defecation, you can see the real anal contractures occurring, the contractures of the skin are occurring. In human being also, the skin can be contracted, the skin can be moved, but the extent of the movement is a comparatively lesser, or the strength of movement is comparatively lesser, but it keeps the anus closed, prevents any finer leakage as such, and that's why it's called as a samvarani. So from my point of view, I would consider the pelvic floor as the pravahani, and the internal sphincters as the visarjani, and the samvarani is the subcutaneous insertion of the external sphincter. Now, if you look at them, these structures in a horizontal manner, it's exactly what you see. The pelvic floor on the outer surface, external sphincter, internal sphincter, and the anal structure. And hence, Sushruta has said they look like Shankhavartani Bhaha. They look like the Shankha, the volulus, or maybe the circular structure of the Shankha. Shankha would have the circular conch, which would have multiple circular like structures, ring like structures, and that kind of an appearance in, and hence the description of the anatomy of the anus is considered to be very optimum, very perfect, and where the function is even more important than the finer structures. When we study the anatomy now, we give a lot of importance to the finer structures like a muscle fiber and a vessel and mucous membrane and so on. So we look at the mucous membrane and the muscles as separate structures. Whereas Sushruta has not considered that way. Instead, Sushruta has considered from the functional point of view a component which pushes and a component which allows the passage of the stools to pass through, and a component which keeps it competent or closed. So that's how there is a difference, but it's not a difference of opinion. It can be made out, and from the study, practical clinical study point of view, whatever Sushruta has mentioned is more practical than the other. Now the dimensions of these bodies are 1.5 angulas. Now what we mean by angula we have already discussed. It is considered to be the width of the middle finger and the ring finger together, kept together, or maybe the two distal phalangeal bones, the length of the two distal phalangeal bones. Anyway, we'll not go into, and angula is not an inch. It depends. It's a biometric analysis, the assessment of the dimensions as per the body. It's a biometric mechanism. The outermost would be up to 1.5 angula. That comes to the dentate line. See, 1.5 angula is corresponding to the dentate line or the mucous cutaneous and mucous junction, mucocutaneous junction at the anal area, which you call as the dentate line. And then the further it would be around 1.5 angula each, and Sarlapancha angula. In total, it becomes 5.5 angulas. That's exactly the length of the anus and a part of the rectum, not the whole rectum. See, when you put your finger in, when you do the rectal examination, the finger goes up to the anorectal junction, and the tip of the finger will be somewhere in the rectum. The whole rectum cannot be palpated, and that's exactly the area which Sushra has considered as a Guda. So whether Guda is to be translated as rectum or anus, I think I would not be able to have a exact translation. I would say the Guda is anus plus a part of the rectum because it's a functionally more important. Functionally, this is the anorectal junction, and the anus is the more important than the whole rectal as such. Now, whatever I have told you about the pressure management, that pressure management in the anus, it can be studied by anal manometry. Now, I have discussed about that pressure issue, the mechanism. Now, that mechanism, how the fecus is maintained and the continence of the stools is maintained, now it is studied by anorectal manometry. Anorectal manometry can be done by a very simple instrument like a balloon which is inserted into the anus and connected to a tube and manometer, or you may have a sophisticated instrument where the defecography, where the pressures can be managed. Now, the mechanism how that is maintained is in the resting pressure, the anal pressure would be around 40 to 70 millimeters, and when the rectum is empty, the rectum would have either 0 or up to 10 millimeters of mercury. The pressure would be, there is a gradient of at least 30 to 40 millimeters of mercury of pressure gradient between the anal and the rectum. The anus gives more pressure in the resting condition, whereas the rectum would have a lesser pressure. When the person is made to squeeze or defecate, that squeezing, during squeezing, the rectal pressure would go up to 100 and 180 millimeters of mercury, and at the same time, the pressure in the anus, that's the external sphincter, internal sphincter area, that gets relaxed, and when it is relaxed, the pressure comes to either 0 or it could be less than 10 millimeters of mercury. So there will be a pressure gradient of around 100 to 100, 90 to 160 millimeters of mercury, and that pressure helps in passage of the defecation. And in the normal situation, even in the resting condition, if there is a pressure, this manometer is inserted in, there is a continuous frequent variations of the frequent waves of pressure changes in the rectum. In the rectum, there will be waves are presented, and that's rectal waves which are produced are rectal anal inhibitory reflexes. That means rectal anal inhibitory reflexes are whenever the stools are entering into the rectum, correspondingly the rectum will be dilating so that there will be no pressure built up. See, in an empty condition, the volume of the rectum is lesser. As the stools are added to, it is a continuous process, formation of the stools is a continuous process. As the stools are added to the rectum, gradually it relaxes, ensuring that the pressure doesn't go beyond the 10 millimeters of mercury in the rectum until a certain limit. So when it reaches a typical level, and on an average it's considered as the rectal capacity is 100 to 250 ml. When it considered reaches to around 100 to 250 cc, there will be a sensation, the rectal sensation will occur. Now the point is, for starting from maybe 0 or maybe 10 ml or 10 cc to 250 ml, there will be no pressure raise. There will be no raise in the pressure because of the inhibitory activities. Inhibitory reflexes would be continuously making that rectum relax. So when you put a manometer, you can see these inhibitory waves gradually occurring. It's a form of inhibitory waves like you will be coming through. So absence of the inhibitory waves also can result in increase in the urge for defecation. See, all this mechanism is important to understand the complications or abnormalities of the defecation, and which is something which we will be discussing later on. Now, all these mechanisms do occur due to a synergistic activity. Now, when the pressure is in the rectum has a is in between 3 to 15 ml, there will be no urge for defecation. When it increases beyond 15 milliliters of mercury, 15 millimeters of mercury, then at that moment there will be a stimulus. The rectum gets a stimulus, like there is this urge for defecation, and that urge for defecation is felt in the hair center, and the whole process of the defecation starts. Now, I will not go into the physiology of the defecation. Normally, when the patient starts the defecation, when a person starts the defecation, the rectal pressure would increase and the anal pressure would reduce. So, and because of that gradient, the stools would pass through. So, normal manometry during the defecation, a defecography or defecation, you will be seeing that pressure of rectum increasing and the pressure of anus getting reduced. But there could be abnormalities. Now, instead of going into the physiology, I will just go into the abnormalities which can occur, and these abnormalities can occur due to various causes. Most of the times, it is a stress which is the cause, or there could be many other neurological conditions, subtle neurological conditions, which may not be named as diseases, and they are called as the dyskinesia. Dyskinesia now, anorectal dyskinesia now is categorized into four varieties, and they are type 1, type 2, type 3, and type 4. Now, in a type 1 dyskinesia, the anal pressure as the person attempts for defecation. Now, make it clear, you have to follow very accurate, otherwise you will be confused. As the patient attempts for defecation, instead of the anal pressure getting reduced, the anal pressure also increases and the rectal pressure also increases. The patient would strain for defecation, and that strain doesn't allow the stools to pass through. So the patient has to strain more. This produces more friction of the fecal material over the anal margin, and that results in the injury. Defecation becomes painful, and the patient would have a constipation. And usually, these patients would try to avoid defecation. They would not go for the stools easily, or once they go to the stools in the lavatory, they will sit for a long time, hours together, and only when they get relaxed and the anus is relaxed, they can pass the stools, and they are more prone to develop the fissures. Now, that part I will come to that later when we discuss about the Vataja, Pittaja, Kaphaja, ulcers. And all these mechanisms are important to understand what Ayurveda says about Vataja, Pittaja, Kaphaja, ulcers. So, in case of type 1, which is more common, the pressure, anal pressure is more. So when you do the parectal examination, all this can be experienced when you do the parectal examination if you are careful. In a common normal person, when you do the parectal examination, when you put the finger in, initially you will feel some resistance, and the finger would not have any resistance in the rectum because the pressure in the rectum is somewhere 0 to 10 mm. So finger would have a free space, and the base of the finger, as the you put the finger in, base of the finger will feel the tone of the internal sphincter. Now, when you do the parectal examination, if you ask the patient to squeeze and now when I say this, when you put the finger in, initially you will feel the external sphincter and the internal sphincter tone of that, and when the finger is inserted beyond, you will feel a free space. Now, when they ask the patient to squeeze, if there is and normally what happens is, you squeeze, as a patient squeezes or attempts to defecate, you will feel more pressure on the tip of the finger, and the base of the finger would have somewhat relaxed, like there will be a pressure gets released. Now, this can be experienced easily if you practice that parectal examination, and if you do some 100 parectal examinations, this pressure can be easily felt. You don't need a manometer, no, don't need a deficogram as such. With the fingers it can, and it's a half a minute's job. You put the pressure in, ask the patient to press down, and you can make out that immediately. So in a normal situation, as the finger is pushed in and ask the patient to take, urge or squeeze as such, the tip of the finger would have now having a more pressure, whereas the base of the finger would be relaxed. Now in a type 1 type, this dyssynergia, as you put the finger in, initially you will have more resistance, and once you have put the finger in and then ask the patient to defecate this squeeze, you will feel the pressure both at the tip as well as base. Your whole of the finger will be squeezed, and that is a sign of the type 1 dyssynergia. Whereas a type 2 dyssynergia, there would be a situation where the rectal pressure doesn't increase, but the anal pressure increases. The patient would have an increase in the anal pressure, and rectal pressure would not increase correspondingly. And in that situation, when the patient is made to squeeze, you will feel more pressure at the base of the finger, but the tip of the finger would not be gripped. That grip in the tip of the finger would be lesser. And that kind of a dyssynergia is called as type 2 dyssynergia. And these patients would usually have a constipation. They also will have constipation, but in these patients, the constipation stools may not be very hard, and the frequency of defecation will be lesser. And every time the patient passes the stools, the patient would pass a small quantity of the stools, but not sufficiently, fully. And it will not be very hard also. And even there is a possibility of a passive leakage of the stools occasionally. A type 3 is a situation where the rectal pressure is very high and the anal pressure is low. So in such conditions, when you put the finger in the anal, during the rectal examination, you will feel a higher resistance in the rectal area, and the anal area there will be a complete relaxation. Now, these kinds of the patients, type 3 dyssynergia, would have a sudden urge for defecation, and they may not be able to tolerate that urge for defecation. Immediately they have to go for the defecation. But frequency of the stools passage would be again lesser, so they will be categorized as even the types of this constipation. Type 4 is usually seen in old age patients or neurological conditions where there will be a total relaxation of the muscles, absence of the tone of the muscles both in the anus and the rectum, and hence the patient would have a incontinence. Most of those patients who have a prolapse or incontinence, they would be of type 4. Now, the quite important is all these dyssynergia can be assessed to a great extent accurately. I would not say 100% accurately, to a great extent accurately and practically sufficient enough to make out the diagnosis by a careful parectal examination. So a careful parectal examination and keeping in mind these facts of the rectal examination would make you to understand about the this dyssynergia easily. You don't need to go for a sophisticated investigation. And this understanding is quite important to make out the whatever we discuss it from the Ayurvedic point of view, like Vata, Pitta, Kapha. I'll come to that part when we go into that description, but this has to be very clearly understood. Important is all the contemporary texts would describe this dyssynergia in relation to the constipation, but their relationship to the type of this hemorrhoid formation are not given equal importance. But what I have observed in my clinical practice is there is a significant relevance of this, and there is a huge difference in the clinical approach, treatment point of view also, and that makes a huge difference in the outcome. The more detail of that, I will come to that part later on and we go into the further discussion. Now the Pura Rupa, before the presentation occurs, the symptoms which would occur as prodromal symptoms of the arshas are Anya Ashraddha, Krishna Takti, Amlika, Parilaha, Vishtambha, Pipasa, Sakti Sadaram, Atopaha, Karsham, Udgarbahulyam, Akshnoh Shvetuhu, Antrakujanam, Gudaparikartanam, Ashanka Panduroga Grahani Dosha Shoshanam, Kasashwaso, Balahani, Brahmaha, Tandra, Nidra, Indriya Dorbadinja. Now, the symptoms it could be produced before the manifestation of the hemorrhoids, either it could be a generalized gastrointestinal tract abnormalities, digestive abnormalities, where the patient may not have the proper digestion, or there could be sore irritations, or burning sensations, or constipation, or excess of thirst, or this barbarigmy like abnormal sounds produced, or hyperperistalsis could occur, or it could be even due to the local symptoms like Gudabarikattanam, where the patient may have itching over the area, or it may present with certain systemic symptoms where anybody would be suspecting Panduroga Grahani Dosha Shosha, like anemia or other gastrointestinal tract abnormalities, or maybe the systemic emaciation also could be the symptoms which can lead to a diagnosis of the hemorrhoids. And systemic symptoms like Kasa Shwasa, Balahani, Brahma, etc. also can occur. जाते श्वेतान्येव प्रभेदतराणि भवन्ति. Once the hemorrhoids are manifested, these symptoms will become more prominent as such. Of course, now this slide has to be, now there is a error of that slide sequence. I think I should have shown this slide earlier. Now, whatever the same type 1, type 3 abnormalities, the same which we have discussed in a difficography. Whatever I have shown is what we can make out with our finger. Now, the same can be felt with the difficography, where you can have a diagrammatic representation. The same type abnormalities, whatever that pressure changes, which I have told when we put the finger in, they can be objectively demonstrated if you have a difficography, and difficography is quite a costly instrument and laborious job. What I say is there is no need to have that difficography. Without that, with the finger alone, you can make out the differences. Anyway, now the same descriptions, whatever I have told, again, the type 1, where the tip of the finger is gripped and has to stay for a long period, fissures are more common, and patients usually they have a habit of manipulation with the fingers, and there is a hard mass of the stools, and most of the times they relate to Vata Prakriti. Now, type 1 is more frequently related to Vata Prakriti. Now, in such a person, when the hemorrhoids do occur, the hemorrhoids would be tatra martat parishushka aruna vivarnani vishama madhyani kadamba pushpa tundikeri nadi mukala suchi mukhakriti bhavanti teihi upadrutah sashulam samhatam upaveshate. The patient would have a very hard stools and with pain, important, that has to be underlined. Then Kati Prishta Pashumya, Budanapi Pradeshesh Chasya Vedana Bhavanti. Patient may have a pain in the abdomen, pelvis, or maybe around the area, buttocks as such. And Gulma Astila Priha Udarani Chasya Tanimatyanya Bhavanti. Patient may develop intra-abdominal pathologies of masses in the abdomen, or fecolids, astila, the fecolids, or even pliha udara. They may have the splenomegaly or maybe the hepatomegaly, also so on. And the patient would have Krishnakvam Nakhanena Dashanavadana Mutra Prishashta Purusha Bhoti. Stools will be blackish in color, and the patient also tends to have a blackish in color. That's what we see in majority of Vata Prakriti conditions. But the most important is the shape of the hemorrhoidal, these masses, arsho masses. Now, shape of the arsho's masses would be like they would be having kadamba pushpa tundikeri nadi mukala suchi mukhakriti. They would be like needle like or kadamba pushpa kriti. So there will be a tundikeri like, that's a pointed projection and comparatively hard. And parishushka, they will be dry, and there will be vishama madhya. There will be a deep ulcer-like appearance. In the modern textbooks, you will find a description of cane-shaped ulcers with the scar formation. The scars are called as tags. This is exactly the description of the fissure in ano with a tag. So, Vata Arshas is a fissure in ano with a tag, and this is very common and most frequently seen in type 1 dyssynergia in case of Vata Prakriti. So, important is clinically you can identify a Vata Arshas easily. And in these patients, when you do the parectal examination, the same thing is felt like initially you will find more resistance as you put the finger in. Most of the times when you put the finger in, patient would have extreme pain, the patient would shout, and everyone in the OPD will know that you are doing a parectal examination. But if we are careful, you can reduce that intensity of the pain, and often it's warned like patient of a fissure, you should not do the parectal examination without taking sufficient precautions. So that's the other way, but because there is a possibility of a sudden shock, the Herxheimer reactions can occur. So unilateral pain would be quite severe. So whenever there is a patient of fissure in Either you try to avoid the parectal examination or do the parectal examination extremely carefully after taking sufficient measures to reduce the intensity of the pain, and that's a quite a critical issue. Otherwise, the patient can go into a neurogenic shock. Anyway, but once you have done the parectal examination, the changes in the grip can be felt as such. That's about the type 1 dyssynergia and Bata Prakriti and whatever I have observed in case of the hemorrhoids conditions. Now, type 2, what we have discussed again already, where the patient would have a straining, but straining doesn't evacuate, takes long time for the actor, and the frequency of purification is reduced, and most of the times this kind of constipation is seen in Pitta Prakriti people. Now, in such a condition, what happens is now because of high anal pressure and low rectal pressure, when the hemorrhoids occur, hemorrhoids do not get projected easily. They remain internal for a long time, and they will be only producing the bleeding. They will not be projected out. Only when you do the proctoscope, you may be able to see the hemorrhoids. But once the hemorrhoids get projected out somehow during some course of the disease, that will remain squeezed, and that tends to become a bluish or stagnated and thrombosed easily. See, hemorrhoid patients, you will have many categories of patients. In many of the patients, the patient may pass the stools. During the passage of the stools, the hemorrhoid may get projected out, and it may get again reduced spontaneously. Whereas in case of the hemorrhoids with the type 2 dyssynergia, the hemorrhoids would not get projected easily. For a long time, the patient would have a hemorrhoid which is remaining internal, and there will be only the bleeding, but the mass is not projected out. But all of a sudden, if somehow the mass gets projected out, it remains over there. It doesn't get reduced, and it tends to get squeezed by deep anal pressure, and hence it becomes congested, thrombosed, and it will be painful at that stage. So you'll have a patient of this sort where the patient will have a history of bleeding for a long time, like years or months. Then all of a sudden, the patient will have a painful mass and coming to you, and when you look at the mass, it will be like this congested and stagnated. Even there could be necrosis. Now, this is exactly what Sushila has mentioned as a pitta, the Neelagrani. The tip would be bluish in color. Talmuni Visarpini, Pitava Bhasani, Ekat Prakashani, or Jihva Samsthanani. They will be highly vascular. Yava Madhyani, the middle portion will be bulged like Yaravka, or Jaloka Vakta Sadhushani. They may look like the mouth of Jaloka because of that surrounding anal opening and a small portion projecting out. Praklinaani bhavanti, there will be more discharge because of the stagnation. It becomes a moist. There will be more discharge. Sadaham sarujiram atijarite. There will be more burning sensation. There will be more bleeding also. And dwaradaha pipas murcha shasya upadravaha bhavanti. Most of the times these result in local inflammation, and that inflammation would produce the systemic inflammatory symptoms. Then Pitatvam Nakana Dashana Vadana Mutra Purishashta Purusho Bhavati. That's in case of the Pittaja Arshas. So a Pittaja Arshas also can be made out clinically, and you can objectively make out with the pressure variations and the parectal examination. Raktajani, a Raktaja variety is again a similar condition where the same Pitta symptoms are occurring, but the Pitta Lakshana would be there, but they will be more vascular, and hence there will be more bleeding. Raktajani, Negro Pravoha Vidruma Kakanantika Palasadashani. There will be more bright red color, and they are relatively bigger masses. And Avagada Purisha Prapeditani, the patient may be having constipated, and Analpa Masak Sahasa Vistirandi, there will be more profuse bleeding. Tasya Jati Pravata Shonitati Yoga Upadravaha Bhavanti. Such patients may have the complications of a massive bleeding, and anemia can occur. Of course, this also can be seen in type 2 dyssynergia. Patients of type 2 dyssynergia, they may have either profuse bleeding and then a sudden development of the compression. The amount of the bleeding will be depending upon the size of the mass and maybe the number of the masses. So, Pittaja and Raktaja are related to the type 2 dyssynergia. Type 3 we will continue in the next session with the type 3 dyssynergia. If there are any questions, I will try to answer and then wind up today. Right, there are no questions. Time is up, so we will close today. Thank you.